Dr. Raj Lakshmi, and I would thank Johnson for providing the opportunity and the platform for discussing on the molecule daratumumab. And I would thank all the participants for giving their valuable time for listening in coming 30-45 minutes. So the sequence of presentation will be initially we will discuss on what actually is a relapsed refractory multiple myeloma, what are the definitions of relapse, what is the definition of recurrent or refractory multiple myeloma, and then we will look into what are the treatment options we have and what are the randomized trials and randomized evidence of daratumumab in relapsed refractory multiple myeloma. So this is the overview. We will see what is the burden of myeloma in India, and then definitions of relapsed refractory or refractory myeloma. What are the investigations and how we diagnose? So what are the guidelines and the retreatment and salvage strategy? And let us then have some case-based discussion and then the recent developments and then the summary. So if you look into multiple myeloma, so what we can note here is the age at presentation is around 60 to 69 years, and this is less common in the northeastern part of India, where we have a lot of GI and gallbladder cancer. We have myeloma dipping in this part of the country, but southern and northern India have a significant higher proportion of patients when compared to rest of the Indian population. And we need to know what is relapse but not refractory, what is relapsed and refractory, and we also need to know what is a primary refractory multiple myeloma. So, relapsed disease means that, so we know myeloma is not a curable disease. There are multiple modalities of treating myeloma, like we have chemotherapy molecules initially, and then we had targeted therapies, especially the IMIDs and the IMIPs, that is the bortezomib, the proteasome inhibitors, and then we had autologous stem cell transplant that actually improves survival. Melphalan is an active drug, and now it's the era of monoclonal antibodies where we speak of a CD138 antibody like daratumumab or ilotuzumab. So this is what we have in treating multiple myeloma. With all that, even date, multiple myeloma is not a curable disease. This is a disease that responds well to therapy. We'll have a treatment-free period, and then again it is going to relapse. And we see an overall survival of around 4 to 6 years with median with whatever treatment options we have. So this is the number, approximate number we can state to a patient when we counsel. So a relapse disease means by its nature, this disease is going to relapse, but it will respond to salvage therapy. This is different from a primary refractory where we do not see response at all, or a relapse disease which then doesn't respond, is both relapsed and refractory. So we need to understand a very fine difference of what a relapse without being refractory, or a primary refractory where the response doesn't happen at all, or a relapsed uh, 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 and also refractory where it comes back and it also does not respond. So if you look into the type of relapse, we speak of biochemical relapse and clinical relapse. Biochemical relapse is a predecessor of a clinical relapse. Before actually we see the clinical manifestations of relapse, we have to pick up the subtle changes biochemically in the blood test or urine test or marrow test, where these are predecessors or they're antecedent of a clinical relapse. So if you look into the biochemical relapse, the definition is more than 25% increase in the lowest confirmed M protein, or an absolute increase of more than zero point 0.5 gram per deciliter, or if you have a more than 25% increase in the serum involved and uninvolved free light chain ratio, or more than 10% absolute increase in bone marrow plasma cells, or you have any new soft tissue lesion, or you have more than 50% increase in the existing plasmacytomas. So these are the biochemical definitions of relapse, which is subtler before actually a clinical relapse develops. So we assess it by measuring the M protein, or we assess by using the serum free light chain ratio, or we assess by the bone marrow plasma cell percentage, or by the plasma cytomas, or the new soft tissue lesions we have, or an absolute increase in the size of the plasma cytoma. So the clinical relapse, as we all know, is basically the CRAP feature, where the calcium will go more than 11 milligram per deciliter, and the creatinine is more than equal to 2, and hemoglobin level falls by more than 2 gram per deciliter, and a hyperviscosity related to serum paraprotein level. This is the IMWG criteria for diagnosis of myeloma. So we have a spectrum of diseases which comes under the plasma cell dyscrasias, ranging from MGUS to a smoldering myeloma to an active multiple myeloma. So basically, these are all plasma cell dyscrasias. These are basically precursors of plasma cells. So it is a clonal proliferation of plasma cells in the bone marrow, which initiates with a monoclonal gammopathy of undetermined significance, where the plasma cell percentage is less than 10% and M protein is less than 3 gram per deciliter, with no end organ damage. Whereas if you have a significantly high bone marrow plasma cell percentage of 10 to 60%, or if you have a M protein of more than 3 gram per deciliter, or a urine 24-hour urinary protein of more than 500, without any end organ damage, then we call it as a smoldering myeloma. These are not separate diseases. It is the burden and the biology of the disease. It is basically a continuum rather than different diseases. So to start with, Magus will be having a small plasma cell clone, little secretion of M protein. As the percentage of cells increase, or the secreted products cause end organ damage, it slowly becomes a multiple myeloma. So these are not different diseases. This is just a continuum of progression from a small clone to a large clone. You can see active multiple myeloma. The only difference between a smoldering and an active myeloma is not just in the quantity of plasma cells, but also the presence of end organ damage. The CRAB features what we call, or if you have a plasma cell percentage more than 60%, that means there's an impending, even in the absence of CRAB, if you have such a high plasma cell percentage, that means it is anyways going to cause CRAB in some time. So it qualifies for a myeloma. And if the free light chain ratio is more than 100, it again means that the burden of disease is so much that the CRAB is going to happen in some time. Therefore, we have to intervene this and treat like an active myeloma. And if you have any focal lesion with the more sensitive investigation like MRI, even then it qualifies for a myeloma. So it may be possible that we pick up MGUS in a patient, and if we can follow them up, and he may not develop into myeloma at all. Whereas you can have a smoldering myeloma which can rapidly progress. So we have to follow them up before they actually become a multiple myeloma. We have to certainly pick them up before we have frank CRAB manifestations. So if you look into the relapse refractory myeloma, we have relapse and refractory, designates disease in patients who achieve at least a minor response or better, and then they become non-responsive while undergoing salvage therapy, or who progress within 2 months of the last therapy. If you have a progression-free interval of less than 2 months, then it becomes a relapsed and refractory. So myeloma by nature is going to relapse, and we label it refractory if it becomes non-responsive or the progression-free interval is less than 2 months. Whereas if we label it primary refractory, where we don't even achieve a minor response, and also it continues to progress. So the term primary refractory is in patients who have never achieved any response, even a minor response with any therapy, and these patients who never achieve a minor response or better, or in whom no significant change in M protein concentration and there is and no evidence of clinical progression is there. So this is basically a primary refractory multiple myeloma, and these are the investigations we usually do. We look for routine blood investigations. We look for the disease burden in the form of beta 2 microglobulin and the paraproteins, especially the SPEP and the urine protein. And we look the bone marrow for the presence of clonal plasma cells, and also we evaluate the genetic basis behind it with the help of FISH or conventional cytogenetics. And we do a skeletal imaging. We do CT, MRI, and even we do a PET CT look into bone lesions or for extramedullary disease. So these are the basic investigations for a multiple myeloma. So basically, myeloma happens in elderly age. As we saw, the median age is about 60 years. Even though in the Indian setting, we see younger myelomas, but usually happens in elderly. We need to look into the age, frailty. We need to look into the end organ function. How is the heart, lung, kidney, liver, all can they take up or tolerate treatment? And we also have to look into how intense or how well these patients can tolerate treatment. And of course, we need to assess the biology of the disease by cytogenetics. We need to look into the host factors, the treatment factors, and also the disease factors. So these are the factors which we consider at relapse: host factors, the disease factors, and the treatment factors. All these decide how well the patient is fit, whether can he undergo autologous transplant, how the organ functions are, these matter, and how rapidly the tumor is multiplying. What are the cytogenetic risk factors, these matter, and what treatment the patient can tolerate. All these influence the relapse or the progression-free interval. So these are the approved regimens we have for a relapsed refractory multiple myeloma. You can see carfilzomib, which is a monotherapy, is approved if we have used at least one prior line of therapy. You can use single agent carfilzomib. You can use a KRD, which is a carfilzomib, lenalidomide, and dexamethasone if you have used 1 to 3 prior lines of therapy. And we have daratumumab monotherapy if we have used more than or equal to 3 previous lines of therapy. We can use daratumumab plus dexamethasone plus lenalidomide uh, uh, if we have used at least more than or equal to 1, or even with bortezomib if we have exhausted one prior therapy. We have darapom dexa, for which we should have exhausted 2 lines of therapy, and we have elotuzumab in combination with pomalidomide or lenalidomide. We should have used more than or equal to 2 lines of therapy, and we have ixazomib and panibenostat. So these are all the treatment options we have in the treatment of multiple myeloma, which is relapsed refractory. You can see the different class of molecules, starting from a proteasome inhibitor, which is carfilzomib. We can see the IMiDs, we can see pomalidomide, we can see lenalidomide, we can see daratumumab, elotuzumab, ixazomib, and panibonostat. So, what we can, the topic of the day today is daratumumab. So, you have approval for monotherapy with daratumumab if we have used at least 3 prior lines of therapy, and we can use daratumumab in combination with dexamethasone or lenalidomide or bortezomib if we have used at least one prior line of therapy. So if you have exhausted 1 line of therapy, then we have approval for daratumumab in relapsed refractory multiple myeloma. We also have evidence in the upfront setting, but the approval is pending. So these are the NCCN guidelines. You can see the preferred regimen in the previously treated multiple myeloma. You can clearly see the category 1 recommendation for daratumumab based regimen. based on the data we have with excellent response rates, side effect profile, and a very impressive progression-free interval we have with daratumumab-based therapy. We also have preferred option for carfilzomib-based therapy and also ixazomib-based therapy and elotuzumab-based therapy. And then you can see low down the other indications which we rarely use in clinical practice. So going further, you can see how to make the best choice for therapy depends on what you have used before. If you had progression on prior lenalidomide based therapy, you can use daratumumab plus lenalidomide. So if you have not used lenalidomide before, then you can use lenalidomide here. You can use daratumumab plus len plus dexa, or you can use carfilzomib, ixazomib, or elotuzumab with lenalidomide. If you have had lenalidomide maintenance before and has progressed, then we can use daratumumab with bortezomib and dexamethasone. We also have approval with pomalidomide. So basically, it depends on what prior treatment we have used. Depending on that, we will choose further lines of therapy. If the patient has progressed on len before, then we can use daratumumab, bortezomib, and dexamethasone, or even we can use daratumumab, pomalidomide, and dexamethasone. So this is the latest data on management of relapsed refractory multiple myeloma. Is basically the Castor and the Pollux trials 4-year follow-up data is what we're going to speak today. And you can see there has always been an argument of reserving the best drug to the later lines. Why should I use an expensive and the most effective drug in the first line? I can use it in the subsequent lines and I can get the equal benefit. This is what the thought process is. But this is not the case. So this may be possible in a patient with a hormone receptor breast cancer where the patient anyways is going to receive subsequent lines of therapy. But that is not the case in a disease which is multiple myeloma, where you can see with each line of therapy, there is a significant attrition or drop in the number of patients receiving subsequent lines of therapy. Therefore, it is always better to offer the best treatment in the earliest lines of therapy. So, if we have molecules like daratumumab, which is the most effective drug we have in the myeloma armamentarium, it is always better to expose the patient in the earlier lines than keeping it reserved in the later lines, because you can see only 23% reaching the fourth line or just 14% reaching the fifth line. And this is in the clinical trial data. But if in the real world data, we have much lesser patients reaching fourth or fifth line of therapy. Therefore, it makes sense to give the best drug earlier than keeping it reserved for subsequent lines because of significant attrition rate. So this is the phase 3 Castor trial 4-year follow-up data. This is a randomized controlled trial in patients in combination with daratumumab, bortezomib, and dexamethasone. So this is the trial design. So phase 3 trial, the key eligibility criteria was they should have received at least one prior line of therapy, and they should have had at least a partial response to one prior line of therapy. They should have had a documented disease progression as per the IMWG criteria, and patients refractory or intolerant to bortezomib prior were basically excluded. So if the patient has had any prior regimen, should have had at least a partial response to any prior regimen, and the patient was not refractory to a proteasome inhibitor, then they were excluded. And the patient should not have had more than or equal to grade 2 peripheral neuropathy. So it was randomization basically into whether it was a bortezomib dexamethasone arm or whether it was a daratumumab bortezomib dexamethasone arm. We all know the dosage of bortezomib and dexamethasone. You can note here that dexamethasone was used as 20 milligram weekly, and bortezomib was 1.3 milligram per meter square subcutaneous weekly for 8 consecutive cycles, and daratumumab was used as 16 milligrams per kg. It is given in 1,000 ml normal saline. Initially, we will give over 6 hours, and later on, if there is not much hypersensitivity in subsequent cycle, we give over 3 hours and 2 hours. The way we do with rituximab, because of higher incidence of hypersensitivity in the initial cycles. You can see the dosing schedule of daratumumab. 16 milligrams per kg in a 60 kg will be around 1,000 milligrams. Uh, uh, you can see it is used as weekly in the first 3 cycles, that is 9 consecutive weeks, and then we use it every 3 weekly from cycle 4 to cycle 8, and then monthly. So the initial 9 consecutive weeks we give with bortezomib, and then we make it 3 weekly from cycle 4 to cycle 8, and then we make it every monthly. So this is the regimen of daratumumab, which is different from rest of the other drugs. So we give bortezomib and dexa weekly, whereas daratumumab is given for 9 successive weeks, followed by every 3 weekly from cycle 4 to cycle 8, and then monthly until progression. So you can see the primary endpoint, which is progression-free survival. The secondary endpoints were time to progression, overall survival, response rates, VGPR, CR, MRD, and time to response, duration of response. So these on the long-term follow-up, you can note at both the time points, you can see a wide separation of curves. Whether you look into a longer follow-up of 19.4 months or 7.4 months, you can see a statistically significant difference in progression-free survival with nearly 69% reduction in the risk of disease progression. You can see the median PFS of nearly 16.7 months versus 7.1 months in the bortezomib dexa arm. So if you add daratumumab, you can nearly have 1.5 years of progression-free interval in the second line therapy or in the subsequent line therapy. So this is the intent to treat population. You can see the progression-free survival at 48 months. At 4 years, you can see nearly 20% of them remaining progression-free. And if only one prior line was used, you can see the median progression-free survival crossing 2 years. So that is quite significant, which we do not see with other conventional anti-myeloma drugs. And we can see 79% reduction in the risk of disease progression. So that is the reason why we have to use the best drug in the earlier lines than keeping it reserved for later lines of therapy. So you can really have a progression-free interval crossing 2 years if you use this novel agent, which we do not see with any other conventional treatment. Just with a progression-free interval crossing 2 years is really significant. And you can also see the subsequent progression-free survival intervals also being longer if we have used daratumumab. And this is also statistically significant. So just to note the hazard ratios of 0.21 and 0.31, which we rarely see in oncology. So this just signifies how effective the drug, even in those patients who are relapsed refractory and in pre-treated patients. You can see a statistically significant difference in the overall response rates, whether you use it in the intent treat population or if you have used one prior line of therapy. You can see the improvement in response rates of 85% versus 63%. And if it were to be only one prior line, the response rate is beyond 90%. And you can note the difference in the MRD negativity, quite statistically significant. So you can see the sustained response beyond 6 months and beyond 12 months, which is also statistically significant when we use daratumumab. So this is the updated PFS on the next subsequent line, the same PFS2 which I was saying. Again, this is also statistically significant. You can see the side effect profile. Most common side effect is basically cytopenias. It is an anti-CD138. Therefore, it also interferes with normal multiplication and has some sort of bone marrow suppressing activity. What you can note is thrombocytopenia being one of the major dose limiting factor. Mainly, you see grade 3 thrombocytopenia in 46% patients and anemia in hardly less than 20% patients. So thrombocytopenia is one of the most concerning and common side effect of daratumumab based therapy. Rest all are not that significant. You can see some sensory neuropathy in 50% and infections and diarrhea in around 35% patients. But otherwise, there is not much concerning side effect. And you can see that treatment related discontinuation was similar, less than 10% patients in both the arms. So, looks to be a very well tolerated drug and has a reasonably good toxicity profile when compared to the bortezomib dexa regimen. So there has been some concerns of second malignancy because these are long-term survivors. That's the reason why we note a higher incidence of MDS. So if you are not giving an effective drug, the patient will not survive to develop second primary malignancy. So just because the patient lives longer, there's an opportunity to pick up a higher incidence of second malignancy. So the conclusion was at a 4-year median follow-up, daratumumab Velcade dexa or bortezomib dexa was superior to bortezomib dexa in relapsed refractory multiple myeloma in terms of response rates, progression-free survival, and even the PFS2 and durable responses and improved MRD negativity. So the PFS benefit with daratumumab Velcade dexa was seen in both standard and high-risk cytogenetic subgroups. The efficacy benefits was more pronounced if you could challenge them in the earlier lines, just post first line therapy. The safety, there were no such alerting signals except a bit of thrombocytopenia, which was manageable. So these updated results support the use of daratumumab in a post first line progression. We can combine daratumumab with bortezomib and dexamethasone, and this should be considered as a standard of care in patients with relapsed refractory multiple myeloma. So, and then after the trial with daratumumab, we also have trial with lenalidomide, the Pollux trial, which is also a phase 3 randomized controlled trial. You can see the randomization is in 1:1 fashion. They would have received one prior line of therapy. Even prior lenalidomide exposure was allowed, but it should not have been refractory. And the creatinine clearance should be more than 30 ml per minute. And the randomization was len-dexa. Len was used as 25 milligram day 1 to day 21 every 4 weekly, and dexa here was used 40 milligram weekly orally. And you can use the regimen of daratumumab that was used. It was little different from that used in the bortezomib trial. There we use 16 milligram per kg IV for 9 consecutive weeks, whereas here we use for 8 successive weeks. And then we use 2 weekly from cycle 3 to cycle 6 and then monthly. So basically it is 8 plus 4, 8 plus 8 and then monthly. So this is how the regimen, initial intense regimen followed by 2 weekly regimen, followed by 4 weekly regimen. Again, the primary endpoint was progression-free survival. Secondary endpoint was time to progression, overall survival, response rates, MRD, duration of response, and time to response. So you can see here, you can see a much better progression-free survival than what we saw in the bortezomib trial. At a follow-up of nearly 44.3 months, you can see the median progression-free survival of 44.5 months, and which is quite statistically significant versus 17.5 months. There was a 56% reduction in the disease progression. So this is the intent to treat population of 45 months progression-free survival versus 17.5 months. And 53 months is when if you have used only one prayer therapy. So it is nearly 4.5 years of progression-free survival what we are seeing if we are using daratumumab plus lenalidomide plus dexamethasone, and if you have used one prayer line of therapy. So even post autologous transplant, we don't see such great responses. And here we see with daratumumab plus len dexa with a median progression-free survival crossing 50 months, which is very significant in clinical practice. These are the exploratory analysis of PFS in subgroups. You can see the standard risk and also in the high risk. In the high risk, the hazard ratio becomes much better. 0.37 is the hazard ratio for a high risk multiple myeloma when compared to the standard risk. You can see the improvement in the survival both in the standard risk and in the high risk. So high cytogenetic risk status defined as having more than one of whether it is translocation 414, 1416 or 17p deletion. The PFS was longer for Dara Lendexa versus Lendexa among patients with both high and standard risk, with the hazard ratio is better in the high risk population than the standard risk. And as we saw with the bortezomib trial, even here we can see an improvement in the PFS2 as well. So these are the statistically significant different response rates. Nearly 93% response rates is what we are seeing, whether you use in the intended population or in the population where one prayer line of therapy was used. And you can see the MRD negative rate also being statistically significant. So adverse events, as we saw, thrombocytopenia being a little concerning, neutropenia, anemia. Other than that, little bit of diarrhea and upper respiratory tract infection being causing. But if you look into the grade 3 toxicities, neutropenia, anemia, and thrombocytopenia, what we can note here is neutropenia being more frequent if you are using with len, whereas if you're using with bortezomib, thrombocytopenia becomes more concerning. And diarrhea is little, the grade 3 diarrhea is again 10% uh, uh, with the daratumumab arm. So the rate of discontinuation was 17%, little bit higher when compared to uh, the bortezomib trial, and invasive second malignancies happened in 6% patients in both the groups. So the conclusion by the author was that at a median follow-up of 4 years, if you can combine daratumumab with lenalidomide and dexamethasone, the progression-free survival benefit is there. Uh, uh, Even in patients with bortezomib refractoriness and better overall response rates, deeper response rates, higher MRD negativity, greater duration of response, and there were no new safety concerns which were noted. And these results gave approval for daratumumab in combination with lenalidomide and dexamethasone in patients who have received one prior line of therapy, including lenalidomide. So these are the summary of phase 2 and 3 clinical trials we have in relapsed refractory multiple myeloma. You can see the progression-free survival rate in the Pollux trial, which was not reached, Aspire trial, which is 26 months, Eloquent study with elotuzumab, and then we have the Castor trial. So these are all the rough, these are the numbers in comparison of different progression-free intervals in relapsed refractory multiple myeloma. So the effect of triplet and doublet combinations in patients with high risk. So this is the data we have of DRD versus Lendexa in high risk cytogenetic subgroup. We could see that the hazard ratios were much better in the high risk subgroup, and these are the toxicity profile of neuropathy, renal infections, diarrhea with different regimen. You can see the Pollux and the casted trial hardly having significant toxicities. So here is a drug which is very efficacious with less side effects. And how do we place the drug and what is the recommendation we have? So whenever there is relapse, we have to confirm whether the biochemical relapse, has it met uh, the IMWG criteria. So if it has not met, then we have to observe and follow up after 2 months. If there is any clinical relapse, if you have an aggressive disease, rapid onset of symptom, new extramedullary plasmacytoma, doubling of M protein, uh, uh, and high risk cytogenetics, with all these, if it is refractory to bortezomib, then we have options of daratumumab plus lenalidomide plus dexamethasone. We have carfilzomib blend dexa. We have elotuzumab blend dexa. We have lendexa. We have carfilzomib dexa, and we have ixazomib plus lendexa. So basically, if you have used bortezomib, you cannot use bortezomib again. Instead, you have to use other agents. You can see daratumumab there being the first option. In those patients where lenalidomide has been used, we can use proteasome inhibitors. Again, the first option is daratumumab, Velcade dexa. So this is the clinical care oncology treatment options at first relapse. You can see again, if you have used lenalidomide and not refractory to lenalidomide before, you can use daratumumab, lenalidomide, dexamethasone, or you can use carfilzomib plus lenalidomide. And if it is refractory to lenalidomide, then we will use daratumumab plus Velcade plus dexa. So these are the options. So if you have used some agent before, or uh, if we have used an IMiD before, then we have to use an alternative drug. We can put daratumumab in subsequent lines. You can see new drugs coming up, panivonostat, serenexer, also being there in the subsequent lines of therapy. So this is a very informative slide. Treatment recommendations in patients who are transplant eligible or young fit patients. If there is a relapse, we have to give a reinduction regimen with a triplet therapy based on what previous regimen we had used. We can use a proteasome inhibitor in case previously we had used IMiDs. So you can see there daratumumab being there as the first option, where we could use daratumumab lendexa. We can use daratumumab Velcade dexa depending on what we have used. If there is more than a partial response, and if the previous relapse was less than 24 months post high dose treatment and autologous stem cell transplant, then we can continue treatment until relapse. If the relapse was more than 24 months post uh, uh, autologous stem cell transplant, or no previous autologous stem cell transplant was done, we can go ahead and consolidate with a autologous stem cell transplant. So just I mean to say that we can use daratumumab both post autologous stem cell transplant and also as a bridge to stem cell transplant. So this is the treatment recommendations. Again, the same thing. It all depends on what you have used in the first line. Depending on that, you will use an alternative regimen, daratumumab being a partner with any other agent. So we can use daratumumab either with the proteasome inhibitor, or we can use daratumumab with a IMiDs, lenalidomide. So retreatment or in relapsed refractory multiple myeloma, involving previously prescribed drugs is an acceptable option if if the previous therapy achieved at least a partial response and if the response was maintained for at least 6 months with an acceptable toxicity profile. So you should have had at least a partial response and the response should have been maintained for at least 6 months. The prospective registry indicate that bortezomib retreatment is a feasible option. The response rates of nearly 46%, including 15% complete responses in retreatment. Again, repeated use of IMID is also a feasible option of a response rate of 44%. Prior to treatment, remaining toxicities due to previous therapy such as neuropathy should be considered. Reuse of previously prescribed drugs may require a less intense dosage and change in administration schedules. For example, we may have to reduce a LEN dose to 15 milligrams or 20 milligrams for a shorter duration, or we may have to use a subcutaneous bortezomib or lesser dose of bortezomib. So we can use retreatment, but you can see the response rates are less than 50% in comparison to a daratumumab based therapy where the response rates were above 80%. So salvage transplantation, a second autologous stem cell transplant with high dose therapy may be an option in transplant eligible patients if we have sufficient stem cell reserve. Previous retrospective analysis have shown in patients who have relapsed more than 1.5 to 2 years after the first autologous transplant may benefit from another auto transplant after a reinduction therapy. So you must have had at least a 2 years of progression-free interval in between if you are planning for a subsequent transplant post reinduction therapy. So you can use a salvage transplant if the patient has remained progression free for at least 24 months. A poor outcome can be predicted for patients who have relapsed less than 1.5 years of auto transplant. So this is how we biologically select subgroup of patients. If a patient relapses within 1.5 years of an autologous transplant, that means it is an aggressive disease. The role of salvage auto transplant is not clear if we have these effective drugs like daratumumab or elotuzumab. Whatever data we have is with IMiDs and some data with proteasome inhibitors, but majority of data was with cytotoxic chemotherapy and with IMiDs. So recent registry-based analysis comparing salvage auto and LOSCT with relapsed refractory multiple myeloma did not show any benefit of allo transplant over auto transplant. However, long-term survivors were only seen with allogenic stem cell transplant. So just to have some take-home message, if you have transplanted a patient and if a patient relapses more than 1.5 years, then we may consider him for another salvage transplantation. If a patient relapses within 1.5 years of prior transplant, that means it's an aggressive disease and he is not going to benefit from a repeat transplant. If you compare allo versus auto, both of them are almost equivalent. And uh, uh, we have the evidence of transplant improving the progression-free survival, and also to some extent there is some evidence of overall survival improvement, not in the era of novel molecules or triplet regimens. This was in the era of cytotoxic or doublet regimen. So as far as case discussion is concerned, so I have an experience of a patient on daratumumab monotherapy in a heavily pre-treated patients. Patient was a high risk multiple myeloma with 414 translocation. He was initially used on a VCD, Cybody based regimen, had a progression free interval of nearly 6 months, and then was challenged with Lendexa. Again, some progression free interval of around 8 months and was on Len maintenance, and again further progressed. Then the patient was re-challenged with Velcade based regimen. So the patient was heavily treated. Even he received some part of melphalan before receiving for brief time, but had poor tolerance. And then we challenged this. So the patient went on to develop multiple plasmacytomas, rib swellings, in the skull, on the ribs, and painful paraparesis the patient had. We had to go on giving radiation. Later on, the patient got support through some reimbursement agencies where the patient went on to take daratumumab for nearly 8 successive weeks, and then the patient had a very good symptomatic benefit in the form of regression of all the extramedullary plasmacytomas, and even the hemoglobin started improving. The transfusion requirements became less. The patient who was basically stretcher bound came to a wheelchair, and the paraparesis part also went on to improve on daratumumab therapy. I could hardly see any side effect except the concerning cytopenias, which was there because of a heavy plasma cell burden in the bone marrow. The neuropathy was not that concerning, and thrombocytopenia requiring little transfusion was a concerning thing, which I could see with daratumumab. So, because of logistic constraints, we are not able to expose majority of patients on daratumumab. But in those whom we have exposed, this is a very effective drug, even if you use in the later line therapy. Coming on to recent developments, these are the drugs that we have. Panibinostat, not an easy drug to handle, very toxic. These HDAC inhibitors are toxic with some modest responses. Selinexor, no experience as of now. It's a exportin inhibitor. It has got its approval even in leukemias now. And we have a fancy alkylating agent, which is melflufen, which we are about to see. We have CAR T cell therapy. We have bispecific T cell engager antibodies, which are all about to come. So we have venetoclax coming up, and we have another CD138 monoclonal antibody drug conjugate, that is indattuximab ravtansine. So these are all the drugs, and we have anti-PD-1 coming up, which is pembrolizumab, which has shown success in solid tumors. So these are the things in pipeline. So, but having said that, so this is novel approaches which we have: pembrolizumab, venetoclax, and all that. So this is the global strategy for treatment strategy at relapse. If you look into the age, you should always consider autologous stem cell transplant in a younger patient. If there is neuropathy, we have to avoid bortezomib and thalidomide. If not, we can give bortezomib weekly and subcutaneously. And if there is nephropathy by light chains, we must be using bortezomib combination or lenalidomide at its adapted dose, or pomalidomide. Bortezomib is preferred if there is nephropathy. In neuropathy, we would prefer lenalidomide or subcutaneous bortezomib. And if you look into disease specific, if it is good prognosis, retreatment with effective first line schedule is feasible. Symptomatic or rapidly progressive disease, we have to switch the class of drug or use novel agents like daratumumab. High risk cytogenetics, preferable to use bortezomib based regimen. And if you look in treatment specific changes, significant response and PFS with prior treatment well tolerated, we can consider retreatment with the same drug. Insufficient response, we have to switch drug class and change regimen. All common regimens exploited, then we have VTD PACE or DCEP and all that. So, to summarize, the therapeutic regimen of choice for relapsed refractory multiple myeloma depends on multiple factors. What was the prior treatment? What is the disease biology? What are the patient related factors? Patient specific issues and prior therapy should be taken into consideration. There are new treatment options. So we have proteasome inhibitors, we have IMiDs, we have HDAC inhibitors, and we have antibodies. And what we could see today, was a drug daratumumab, which is an anti-CD138 antibody, which showed statistically significant progression-free survival, duration of response, overall response rates, and a safety and a favorable safety profile. You can use it in at least if there is one prior line of therapy. We have approval for its use both in combination with IMiDs, that is lenalidomide, and also with proteasome inhibitors, that is bortezomib. So we have a wonderful drug to use, and we could see a progression-free interval crossing 4 years, which we have hardly seen with any myeloma treatment. We can use it before transplant as a bridge, or you can also use post autologous stem cell transplant. So with this, I would conclude the presentation, and I would again thank everyone for their patient listening, and I would thank Johnson and Johnson for providing the opportunity. Uh, for